So welcome to the detailed description and discussion on the part of the adenotonsillar diseases. The first part to be started with is the normal anatomy and physiology of the adenotonsillar tissues. So to understand better about the pathophysiological processes, the diseases, their symptoms and their management. So let's start with it. So firstly, to start with these two images on the sagittal section of our head and neck, in this very image, the whole area of the head and neck in its sagittal section is shown. If we zoom this area in, then the image looks like something like this, correct? So here in this very image we can see the part of the nasal cavity, its turbinates, that is the superior turbinate, middle turbinate and the inferior turbinate, and the part of the nasopharynx, the part of oral cavity, and the part of the oropharynx, correct? Now in the pharyngeal area there are some mucosa associated lymphoid tissues, that is mold, which are connected to each other physiologically more than anatomically, correct? So these structures make up an inner ring of Waldeyer. These are some lymphoid tissues in the pharyngeal region, obviously in the region of the nasopharynx and oropharynx. In the nasopharynx there are two mucosa associated lymphoid tissues, one at the junction of the roof and the posterior wall of the nasopharynx, and that very structure is known as nasopharyngeal tonsils or adenoids. There is also the eustachian tube opening, and surrounding the eustachian tube opening in the region of the torus tubarius you can actually find some tonsil again, and that is known as the tubal tonsils or Garlax tonsils. Then there is this very big lymphoid tissue at the region of the tonsillar fossa, being bounded anteriorly by the palatoglossal fold, that is the anterior pillar, and the palatopharyngeal fold, that is the posterior pillar, and this tonsil is nothing but the most important tonsils, and that is the palatine tonsils. Correct? There are also there may also be some tonsils at the region of the base of the tongue, and they are nothing but the lingual tonsils. Even there can be some lymphatic nodules present at the at the posterior pharyngeal wall, and these are nothing but the lymphatic nodules on posterior pharyngeal wall. Correct? So they actually are connected physiologically. These all lymphoid structures are connected to each other physiologically more than anatomically, and they make up one ring, inner ring of Waldeyer. Correct? So our next slide will be describing on the part of these tonsils. So you see, I have already said you regarding the inner ring, which is made up of the adenoids. Secondly, the tubal tonsils at the region of the torus tubarius surrounding the eustachian tube or orifice in the nasopharynx. These are nothing but the palatine tonsils, and this one is the lingual tonsil. And there can also be some posterior pharyngeal wall nodules, as I have already said you. Yes, there can also be some lateral pharyngeal band of lymphoid tissue present also on the lateral pharyngeal wall. Correct? So these all are actually making the Waldeyr's ring on the inner part, whereas on the outer side there is also a Waldeyer ring present, and this is consisting of firstly the retropharyngeal lymph nodes, which are the primary Echelian nodes for carcinoma nasopharynx. Correct? Because nasopharynx primarily drains into these retropharyngeal nodes most commonly. Okay, and rather it is the first node to be drained. Now the second ones are the jugulodigastric nodes, which are the most important lymphatic drainage site for the palatine tonsils, and in chronic tonsillitis patients these jugulodigastric lymph nodes are mostly found to be enlarged, and they may be palpable with some tenderness. So the palpable tender jugulodigastric lymph node present in chronic tonsillitis is known as Wood's sign. Correct. Then what you need to know now is the point of these two, and they are the submandibular group of lymph nodes, that is level 1B of cervical group of lymph nodes, and these are the level 1A, that is your submental group of lymph nodes. Correct? So these make up the outer ring of Waldeyer. Now, the adenoids actually are a superficial subepithelial collection of lymphoid tissue at the junction of the root and the posterior lobe nasopharynx, as I have already said you, but they causes the overlying mucous membrane to be thrown. So you see, to be thrown into some folds, correct? To be thrown into these radiating folds, and they make up the furrows. They make up the furrows on the superficial surface of this adenoid tissue. This is about the superficial mucosal surface of the adenoid. Tubal tonsils, when they are enlarged due to some infection, they may cause eustachian tube obstruction. Correct? So now the palatine tonsils are the two masses of the lymphoid tissue situated in the lateral wall of the oropharynx, firstly, and each tonsil is placed between the palatoglossal arch, that is the palatoglossal muscle is actually making the anterior pillar anteriorly, and the palatopharyngeus muscle making the palatopharyngeal fold or the posterior pillar posteriorly. Okay, and the tonsillar fossa is in between these two pillars. Next, the medial surface of this tonsil is free and it projects into the pharynx. Importantly, the tonsil is actually having one lateral surface, okay, and one medial surface. The medial surface has got some pits, about 12 to 15 pits, and these are known as the crypts. These crypts are actually extending throughout the substance of the tonsil, and they are getting branched also within the substance of the tonsil. Correct? So like this. So they are actually not ending at that point, they are extending throughout the substance of the tonsil. Okay, now, but one of them at the upper pole of the tonsil is the deepest, and that very crypt is known as crypta magna or intratonsillar cleft. Crypta magna or intratonsillar cleft. Clear? The lateral surface, it is actually covered by a fibrous capsule which is separated from the muscular wall and is being formed by the superior constrictor muscle with the styloglossus muscle on its lateral side. Correct? So actually, firstly there is a buccopharyngeal fascia, then there are two muscles over here, and they are the superior constrictor muscle and the styloglossus muscle Correct? Now, importantly, we have already said you that anteriorly there is one anterior pillar being made up of the palatoglossus muscle. Posteriorly there is one posterior pillar again being made up of the palatopharyngeal muscle. Correct. Now, why the tonsil is not getting down or is not getting fallen off from the tonsillar fossa within the pharynx? What are the structures which are actually getting the tonsil within its space? So to start with the part, we need to understand about two mucosal membranes, and these two mucosal membranes actually prevent to prevent the tonsils to get fallen off within the pharynx. Correct. And what are they? Firstly, there is one mucosal membrane coming out of this anterior pillar to the anteroinferior part or anteroinferior pole of the tonsil, and this mucous membrane which is actually preventing the tonsil to get outward and downward, that is nothing but the plica triangularis, as pretty much evident from the picture being drawn over here. Correct. Secondly, there is also another mucosal membrane, which is again coming out of this anterior pillar only, but going up to the posterior pillar across the superior pole of the tonsil. So there is another one mucosal membrane going from the anterior pillar up to the posterior pillar across the superior pole, and that is known as plica semilunaris. So you know now at this moment about the plica triangularis and plica semilunaris, which actually prevent the tonsils to getting fallen off within the pharynx. Now, at the anteroinferior part, the capsule is very much firmly attached in the side of the tongue, and the tonsillar branch of the facial artery with the two veins enters the tonsil at this point. So from the anteroinferior part only, there is the lower pole of the tonsil through which the tonsillar branch of the facial artery with the two veins enter. Correct. Next, the paratonsillar veins, very much important ones. They descend from the soft palate onto the lateral aspect of the capsule of the tonsil, and it is actually responsible for the massive bleeding if injured during operation. So paratonsillar veins are the most important source of the operative primary hemorrhage during tonsillectomy. Then the internal carotid artery lies 2.5 centimeter behind and lateral to the tonsil, and this is very much important to understand because sometimes the novice surgeons may during their training period may actually sometimes, very rarely, may actually go through this area, and if entered, this may cause obviously massive hemorrhage, and the patient may even collapse during operation. So these images actually present the things which have been already discussed. Now you see, these are the tonsils being supported anteriorly by the anterior pillar and the posteriorly by the posterior pillar. So this is anteriorly the anterior pillar and this is the posterior pillar. And I have also said you about these crypts. Okay, these are the crypts. There is the crypta magna at the upper pole, and you know already that this is posterior pillar, this is anterior pillar made by the palatoglossus muscle, this is posterior pillar made by the palatopharyngeus muscle. In this very image they have actually demonstrated about the tonsillar bed also, but I will be describing this very part in the next slide. So the tonsillar bed. The tonsillar bed is made up of, firstly, obviously from inside outwards, medially, from medial to lateral. The structures are, firstly, the pharyngobasillar fascia. The pharyngobasillar fascia. So pharyngobasillar fascia is the most medial structure making the tonsillar bed. Secondly, there is actually your those two muscles, as I have already discussed, the superior constrictor muscle and the palatopharyngeus muscle, which makes up the posterior pillar. Next, there are the there is the styloglossus. So actually, then there is the buccopharyngeal fascia. This is the buccopharyngeal fascia, which is overlying. Okay, and then there is the styloglossus muscle. There is the styloglossus muscle. Then there is also a nerve nearby, that is cranial nerve 9. Okay, then the facial artery. Then the facial artery, from which the tonsillar artery starts, and it is supplying the tonsil from its lower pole, as I have already said you. So, and the internal carotid artery also, correct, as I have already told you earlier. Now, styloid process. This is very much important, that the styloid process is actually at this point is here, correct, but it is mostly not palpable intraorally, only if the styloid process is enlarged and patient comes to us with the features of stylalgia, that is the glossopharyngeal neuralgia being caused due to the effect of persistent styloid process being causing penetration of this nerve. Okay, so there is neuropraxia, and there can even be pain around the ear region, and that is stylalgia presenting with. During that phase also, the styloid process, if is enlarged, it may be palpated intraorally through the tonsillar fossa. So it is palpated bimanually. One finger should be placed in the outer side and the other finger is to be placed in the inner side, and the inner finger should be placed in the lower part of the tonsillar fossa only, and the styloid process, if enlarged, can be palpated bimanually by this process. Even if the patient requires styloidectomy for the symptoms to get relieved of, the styloid process is approached through the tonsillar bed only, after tonsillectomy. Correct? Next, there is another very important area in between the tonsil lower part and the dorsum of the tongue, and that is the tonsillolingual sulcus. This tonsillolingual sulcus is very much important because this is mostly a very common site for the cancer. Correct? So this is a hidden site for carcinoma. Okay. Now coming to the point of the blood supply of the tonsils. Correct? So blood supply of the tonsils you should be known of. Blood supply includes firstly the arterial supply, and it is very much important for your exams. The arterial supply of the tonsil, it is tonsillar branch of the fascial artery, then tonsillar branches of the ascending palatine artery, which is again a branch of the fascial artery, ascending pharyngeal artery, greater palatine branch of the internal maxillary artery, and dorsalis linguae branch of the lingual artery also supply it. Correct? So you can well understand there is the most important blood supply to the tonsil comes from the tonsillar artery. Okay, let me change the color. Tonsillar artery, which is actually a branch from this very fascial artery, which is again a branch from the external carotid artery. Correct? Now there is another blood supply is coming out of the dorsal linguae branch, which is this one, from the lingual artery, which is again a branch from the external carotid artery. Then there is again one branch coming out of this very artery, which is nothing but the ascending pharyngeal artery, and there is also another arterial supply from the greater palatine branch of the internal maxillary artery and the descending palatine artery Correct? Next, veins. Very importantly, the one or more veins leave the lower part of the deeper aspect of the tonsil, and after piercing the superior constrictor muscle, they join firstly the paratonsillar vein, then pharyngeal plexus, then common fascial vein. Correct? Okay. Now, nerve supply. So nerve supply is derived from the sphenopalatine ganglion, very important, through the lesser palatine nerves and glossopharyngeal nerve. Correct? Coming to the lymphatic drainage, as I have already said you earlier that the most important lymphatic drainage site for the palatine tonsils are the jugulotrigastric lymph nodes, and they are situated 1.25 cm below and behind the angle of the mandible. So that is the most important thing. Next, coming to the point of the histopathology. So in the point of the histopathology, there is the tonsils actually consisting of the collections of the lymphoid tissue arranged in the form of the follicles, and thus you will see the follicles with presence of crypts. So these are your crypts. These are crypts. Okay, these are crypts. Then these crypts are actually lined by stratified squamous non-keratinized epithelium. Stratified squamous non-keratinized epithelium with some sub-epithelial lymphatic nodules are seen. Sub-epithelial lymphatic nodules are seen with their germinal centers, and the mucus glands are also seen. Correct? Mucus glands are also seen. Correct? Now each follicle is surrounded by plexus of lymph vessels passing to the upper deep cervical lymph nodes, especially the jugulotrigastric group of lymph nodes. It differs from lymph node by having some squamous epithelium firstly. Secondly, there is no subcapsular lymphatic space, and there are also no afferents to the tonsil as like that of to a lymph node. So that is of very much importance to understand, correct? Okay, next, um, so now coming to the point of the adenoids. Adenoids again are the nasopharyngeal tonsils, as I have discussed earlier, and situated at the junction of the roof and the posterior wall of the nasopharynx, correct? Histopathologically, it is consisting of or composed of some vertical ridges of lymphoid tissue separated by deep clefts. The covering epithelium is of three types: ciliated pseudostratified columnar, stratified squamous, and transitional variant. Unlike palatine tonsils, adenoids have no crypts, no capsule. Important. Now, adenoids have a typical growth pattern, and you need to know that, correct? So, firstly, it actually is present at birth only, shows physiological enlargement up to 6 years of age. Then from 6 or 7 to about 10 to 12 years of age, okay, it shows a plateau phase. Then the adenoid is actually atrophies, and it starts atrophying from the age of puberty mostly, and it is completely disappeared by the age of 15 to 20 years of age, correct? So very importantly, if any patient comes to you with an adenoid hypertrophy at the age of 15 to 20, you must have to intervene, correct? Otherwise he or she may complain of nasal obstruction, correct? Now coming to the blood supply of the adenoids, it is of utmost importance because most students actually focus on the blood supply of the tonsils. So most examiners are actually um, they actually tend to ask more about the blood supply of the adenoids, so to just um, check your knowledge regarding the blood supply of the adenoids also, correct? So that is, firstly, it is being supplied by the ascending palatine branch of the facial artery, then ascending pharyngeal branch of the external carotid artery. Again, then these two were actually same as that of the tonsil, palatine tonsils. Then pharyngeal branch of the third part of the maxillary artery, then ascending cervical branch of the inferior thyroid artery of the thyrocervical trunk also supplies the adenoids. Now, the lymphatic drainage. From the adenoid, they drain into the upper jugular nodes directly. Very importantly, upper jugular nodes directly, or even they may go indirectly via the retropharyngeal and parapharyngeal nodes, correct? So this is of again utmost importance, directly into the upper jugular nodes, or may indirectly go into the upper jugular nodes only via retropharyngeal and parapharyngeal nodes. Nerve supply, again through cranial nerve 9 and 10. They carry sensation, referred otalgia means referred earache due to adenoiditis is again mediated through them only, correct? Now a very important topic of the differences between the palatine tonsil, adenoid, and the lingual tonsil. That is, firstly, the location. This is palatine tonsils are located laterally in the oropharynx. Adenoid Obviously you know very well than me that it is located in the posterior superior and the nasopharynx, in the midline between the two thoracic areas, at the junction of the roof and the posterior of the nasopharynx. Lingual tonsil is actually located in the base of the tongue in the midline. In relation to age, you know already, palatine tonsil grows maximum till 8 years, persists even in adult life. Lingual tonsil persists even after 8 years, no problem. Adenoid, you know already, grows to maximum till 8 to 7 years, 6 to 7 years, sorry, and then atrophy starts at puberty, disappears by 15 to 20 years. Correct? Then surface, you know again, palatine tonsil shows multiple crypts on medial surface, whereas adenoid has got no crypts, rather they have got furrows. Okay, then lingual tonsil, yes, there are crypts present. Then mucosal covering. Palatine tonsil, there is non-keratinized squamous epithelium. Palatine tonsil, there is non-keratinized squamous epithelium, mostly with the crypts. Correct? And adenoids, again, they have mostly a ciliated columnar epithelium. Although they may have three types of covering epitheliums, including ciliated columnar epithelium, stratified squamous, and transitional, but most commonly it is ciliated columnar. Lingual tonsil, it is non-keratinized squamous epithelium again. Coming to capsule, palatine tonsil present, which is condensed pharyngobasillar, first I have already said you, whereas adenoids and lingual tonsils are absent. They have got no capsule over them. Correct? Then pain on inflammation. Palatine tonsil, obviously tonsillitis, pain occurs in the throat. Lingual tonsil, again throat pain may happen, but adenoid, they generally don't ache. That means there is no pain or inflammation of adenoid. Correct? In the nasopharynx region, but obviously there can be a referred pain to the ear. That is a different issue, but mostly it is absent on adenoid area. Correct? This is the last slide for today's discussion, and that is about the functions of the tonsils and adenoids. It is firstly the immunology and the host defenses. The T lymphocytes in the parafollicular region provide cell mediated immunity against various viruses, bacteria, and fungi. T lymphocytes, once the pathogens enter into these lymphoid aggregations, they are dealt by IgM and IgG antibodies, which are produced by plasma cells. Then sentinels are actually these tonsils and adenoids are actually acting as sentinels at the portal of the adeno-digestive tract. So the oropharyngeal subepithelial muscles or lymphoid tissues, which are part of the Waldeyr's ring, act as protective sentinels against harmful intruders into the air and food passages. Crypts in the tonsils increase the surface area for contact with the foreign substances. Correct? And the last one is the antibody production, especially the secretory IgA. So T lymphocytes were actually providing the CMI, that is cell mediated immunity, whereas the B lymphocytes in the germinal centers of these lymphatic nodules, the lymphoid follicles, actually produce antibodies like immunoglobulin A, okay, which are important for our humoral immunity. So I think that completes our discussion on the anatomy and physiology of these adenoid and tonsillar tissues. So thank you very much for your kind listening.